Hi, I'm Dr. Brian Kaufman, a retired family doctor and the co-founder, chief medical officer, executive vice president of the nonprofit CLL Society. Dr. Eichhorst?
Yes, thank you very much for the kind invitation. My name is Barbara Eichhorst. I'm a hematologist and oncologist at the University of Cologne in Germany, and I'm also chair of the German CLL Study Group. Thank you very much for having me here.
Well, the German CLL Study Group has done incredible research over the years and really advanced the care in CLL. But one area that we still have a great unmet need is the management of Richter's transformation. And at ASH in last year, you presented some research about a combination of two therapies that looked more promising. Can you share with patients and their care partners a little bit about that research and why it's important and what the results were?
Yes, certainly. So Richter transformation, particularly the form where this CLL develops into an aggressive lymphoma, what we call diffuse large B-cell lymphoma. Sometimes it's also less aggressive Hodgkin's lymphoma, which we can treat better. But the DLBCL type is really difficult to treat because these type of lymphoma does not respond for a long time to the standard treatment, which is a combination of antibody and chemotherapy. The regimen we use here is R-CHOP or R-CHOP usually. So therefore, we were, as other groups around the world, trying to find a schedule which is more specifically working than just, again, intensive chemotherapy. And we evaluated in patients needing first line of the Richter transformation, so CLL may have had previous treatment, a combination of a BTK inhibitor, Zanubrutinib, which is also approved for CLL, in combination with a checkpoint inhibitor, which name is Tislelizumab. And this checkpoint inhibitor in general, they don't work very well in CLL. They work better in Richter transformation because they are activating the immune system, and the Richter transformed cells, they are more sensitive to actions of the immune system than the normal CLL cell. And therefore, there have been studies been done before evaluating these checkpoint inhibitors, which are antibodies, as monotherapy, and they have shown some response, but many patients were progressing on the treatment, and therefore we wanted to evaluate a combination that we use on the one hand side the BTK inhibitor, which work also not too much in Richter transformation, combine that with the antibody. We treated 48 patients with Richter transformation with this combination. It was 3 continuous treatment with Zanubrutinib and the antibody given every 3 to 4 weeks as a continuous treatment. And what we've seen that the overall response after 6 cycles of treatment was 60%, which is maybe not so high as you may expect, but it is higher than reported for many of the trials on chemoimmunotherapy. What is interesting and good news for patients that after 1 year, 47% of the patients are still in remission, and more importantly, 75% of the patients are still alive. And this is a good number in comparison to historic study data where we've seen that unfortunately with this type of aggressiveness of disease, after 1 year, many patients died already. So what we do see is, so some patients are already progressing from the beginning, but those patients who respond to the treatment, they may have continuous response, and we have a couple of patients who are on the study treatment already for 3 years. So they continue to respond. They have no more symptoms from the Richter transformation. And also there may be some residual lymph nodes, but more or less they do not have any more disease burden. And in addition to that, the treatment is well tolerated. Patients may have some reduced leukocytes, and among the infections we have primarily seen urinary tract infections. But overall, the treatment is well tolerated by the patients. And so what we do now, the next step, is that we add another drug to that in order to achieve this higher response rates in patients with this aggressive disease.
So to understand, if you're one of those patients who's responding well, do you stay on both drugs for until there's disease progression?
Correct. Yeah, that's how we proceed. They just stay on the drugs. Of course, in patients who are now in their second or third year on treatment, they may prolong the interval between the antibody infusion, but in general, they stay on the drug. Yeah.
Well, from what I understand, having 75% patients alive after a year is an excellent result in Richter's, because that's generally you've got patients living in a matter of months, with just chemotherapy. And this is a non-chemo approach, which to me sounds very exciting. Where is this going, and what are the next steps for patients?
Yeah, so what we are evaluating now is that we add another drug to that combination to have a little bit more intensification of the treatment, to have overall a higher overall response rate, maybe hopefully also higher overall survival for the patients. That's the one thing. The other one is that we hope that also patients outside clinical trials can get this combination treatment, because it's not yet approved, but hopefully the checkpoint inhibitor we use will be accessible soon. Probably you could also exchange that to other checkpoint inhibitors which are on the market. However, it's just officially not approved. So physicians should try to get that treatment refunded, particularly when they think the patients are not fit enough for getting the standard treatment, which would be in young patients, chemoimmunotherapy, and then the allogeneic stem cell transplantation. What we have seen in our trial, I think this is also interesting to see, that we had 6 or 7 patients who first went on the trial and then had a slow relapse and then came to allogeneic stem cell transplantation. And these transplantations worked out quite well, because patients were not heavily pretreated, they were not so exhausted than when you use chemotherapy and other chemotherapy in trying to get to the stem cell transplantation.
Because the disease has to be in a full retreat in order for a transplant to have a level of success. And I guess that's still the goal, is to consolidate these therapies with transplant. Though when you get 3 years out, you're starting to think, hey, maybe I don't need a transplant. Maybe that's part of the difficult decision for patient and physician.
Yeah, that's certainly difficult, but I mean, even for this very poor prognostic disease, there are now bispecific antibodies. We will do another clinical trial where we test a bispecific in combination with another BTK inhibitor and compare that to the standard treatment, to the R-CHOP treatment, which is necessary in order to say really safely this is the better treatment option. And I think particularly bispecifics are also encouraging in this type of disease, and certainly CAR T cells, for example, for consolidation. So this is still a horrible diagnosis, but my advice would be for patients trying to get on a clinical trial wherever, which allows entry for those patients, because there are probably within targeted options, probably combinations or combinations followed by a different type of consolidation. This is potentially a way where we could get really long-term control of this transformation.
Dr. Eichhorst, I always learn something when I talk with you. Thanks so much for the research you're doing. Thank you.
Thank you very much for the kind invitation.